Please.
Welcome to SNU Hospital. I'm Hyo-Soo Kim. My co-operator is Dr. Jung-Gyu Han and Do-yeon Hwang and Seung-do Lee. And specialist Solbit Lee, Youngmin, 이게 뭐였지? 그 다음에 유서진, 김동구, and professor in anesthesia department is Dr. Yeonjung Cho. We prepared the TAVI accurate case again. Slide, please.
들려야 돼요, 저. 네, 들려야 돼요. 들려야 돼요.
81 years old male. Chief complaint is worsening dyspnea. Echo showed mild to moderate AES 4 years ago. For 4 years, it progressed to severe AES.
너무 소음이 심한데요, 근데?
Demographic characteristics shown here, plus medication. Renal function is good, 87. Target is severe AES, plus. Risk is very low, plus. X-ray normal, ECG just LVH, plus. Echo showed normal wall motion, good function, LVH, severe ES, mild AR, plus. Valve area 0.9, mean gradient 52, Vmax 4.7, plus. Arteriofemoral artery looks unremarkable in this cohort of TAVI, plus. Renal artery aortic arch, good, plus. Valve calcification is eccentric, heavy on right and none. Length of calcium chunk on the right cusp is about 14 millimeter. Plus, calcium chunk on the right coronary cusp extends toward the annulus and partly LVOT. Diameter is 25.6 annulus, 24.2 LVOT. Plus, as the junction is big, 30, sinus space is really wide, more than 30 in all 3 sinuses. Plus, coronary height is 16, as junction height is about 18 and 21. Here, coronary height on the right is about 15.6. Previously, the length of calcium chunk is 14 millimeter. Because even though it is deflected by a valve, it may not obstruct RCA. Plus, annulus to memory septum length is about 5.5, a little bit shorter considering the body size of this 81 heavy-looking male. Plus, left angle 3 cusp view, aleocranial 2-4, cusp of left view, areocaudal 18-24. Plus, this is a summary of the measurement. Plus, in Sapien 3 Ultra, we can use 26 millimeter valve with 11% oversizing and 1 cc overfill. It's good digit. Plus, with Evolut Pro 29, we can achieve 17% oversizing, also good. Plus, with Accurate Neo 27, we also achieve 18% oversizing. That's good. When you see the size matrix panel, the upper panel is based on the actual diameter. Actual diameter is lower crown diameter. That is actually 3 millimeter bigger than nominal diameter. Because when we see the 27 millimeter valve, actual diameter is 30. Thus, oversizing is for 18%. A lower panel is nominal diameter. So nominal diet-based oversizing is about 6%. So please consider such kind of difference. So please declare which diameter, nominal diameter versus actual diameter. Then say the oversizing index in terms of accurate. Plus, Oversize index is all optimized among 3 valves. Additionally, these patients have 2-point calcium chunk on RC leaflet extending to annulus and LVOT. It is associated with issues of safety and probable leakage. Minor issues, length of membrane septum is not long enough. He may be prone to AV block after TAVI. Plus, here is once again 9 clinical conditions to choose valve. There are 4 risk of leakage, tear, AV block, coronary obstruction. This patient is a little bit associated with these risks. Considering these 4 risks, we can see Acroneo has the highest rank. Additionally, when we see the future of these patients, longevity, thrombosis, orifice area, and future coronary accessibility is important virtue. With this aspect, once again, Acroneo has the highest rank. Plus, when you see the component of Acroneo 2, the first release was upper crown. Secondly, stabilization arches. Finally, we deploy a lower crown that is covered by perivalvular seal, porcine pericardium. Plus, dimension of Acroneo 2 is shown here. Nominal diameter 27 means waist diameter. Actual diameter is 3 millimeter bigger, 30 millimeter at lower crown diameter. Lower crown height is about 14 millimeter. The central 7 millimeter is a landing zone. Plus, there are several data to compare accurate versus average, accurate versus sapient. This is a retrospective registry of more than 2,100 TAVI patients treated with accurate 700 or more, Evolut 1,400. 1 month device success rate is similar to each other, but safety feature is better with accurate, especially lower incidence of permanent pacemaker and lower incidence of severe leakage. Plus, another data is published Eurointervention last year. They compare Acroneo 2 and Sapien 3 Ultra. Over 1,300 patients from Germany were compared, treated with Accurate and Sapien. After one-to-one matching, they compare Acroneo 2 versus Sapien 3 Ultra in 472 pairs. Thus, this is result. Probable leakage is similar to each other. Mean gradient is significantly lower with Accurate. Thus, PPM was significantly less with Accurate, less than 3%, while 15% in Sapien 3 Ultra. Plus, finally, there are one randomized controlled trial to compare Accurate Neo versus Sapien 3 in scope 1. Sample size is more than 700 patients randomized into either stent, either TAVI. Plus, 3 years mortality rate was exactly the same, 24%. Soft endpoint was different. Mean effective orifice area was bigger than 1.7 in Accurate, but smaller than 1.6 in Sapien. Pressure gradient, less than 10 in Accurate, more than 10 in Sapien. Plus, thus we consider Accurate Neo performance is acceptable and satisfactory. To summarize the issues of these patients, their calcium chunk, length of membrane septum is just short. Considering longevity of valve, I chose Accurate Neo 2, 27 millimeter valve. Okay.
Dr. Kim, is your plan is try to fix this patient is Accurate Neo to 27 millimeter, right?
Yeah. Fluoro.
We would like to discuss about this patient with the several panelists.
So I have no experience with the Accurate Neo. David Cohen, although, again, I've watched Dr. Kim do a number of them, and it seems like a very intriguing device. We don't have as much long-term data with it as we do with the other devices, especially the Neo 2. But I think, it seems like a very reasonable choice here. I honestly think that any of the valves, as you noted, would have been perfectly reasonable. Also, I think the advantages that you're noting are, some of them are theoretical more than proven. Although I think the very low pacemaker rate seems to be a fairly consistent finding. So I think this is a very reasonable choice, although I think there would be others that could be made as well. I did notice how tortuous the iliacs are, and I'll be interested in watching how it passes through the iliacs.
What about Michael Lee and Dr. Hayashida? Would you comment of the valve selection and the patient treatment strategy?
Yeah, we have actually just started to use the Accurate Neo 2. It's a great valve. I think all the features mentioned by Dr. Kim
플로로 보고 있나?
are correct. And it's a low-risk patient, very, very favorable anatomy.
그러니까
I
학회장을
think
항상
all the
보여줘.
valves actually will do their job. In this particular case, with the short membranous septum, if we want to have future coronary access, I think Accurate Neo 2 is a fair choice.
Low risk patient procedure in this patient is only one concern is the LVOT calcium. If you have experience about that, is what about the presence of the LVOT calcium?
Actually, we don't have the accurate Neo 2 in our country because it's not appropriate yet. And this anatomy that allows the maybe either the Venturi Ultra or Evolut or Navigator valve. And the concern is the very huge calcification on the leaflet. And hopefully the accurate device will expand much better. And I've heard that this device was also associated with the lower incidence of pacemaker implantation. So I'm really looking forward to learning from this case.
Dr. Finkelstein and Dr. Damon, please.
You can't argue with the beautiful way that Dr. Kim is presenting again and again with his tables and perfect presentation. There is, and I totally agree, there is only one thing that I want to say about it, about the calcium. You know, we're arguing again and again that the calcium is against a balloon expandable, and you probably should choose a self-expandable. Now look guys, we are not anymore in those days that we are agreeing to go for less than perfect results. Now go through all the cases that you have done with calcium in the annulus, and you will see that you have done post-dilatation in order to improve it. A self-expandable with a post-dilatation balloon is a balloon expandable. So I totally agree, but this is not the argument. If it's dangerous because of the calcium, it's dangerous for all of them, okay? And then we should consider surgery. But if you can use anything, you can use them all, as a matter of fact, because you are not going to compromise on less than perfect results.
Dr. Damon,
Yes,
do you have experience of the Accurate Neo in your institute?
Yes, we do.
Okay,
we do.
please comment.
I like the presentation. Great case. I think I agree with most of the things that were said. The Accurate is an interesting platform with gradients that appear to be very favorable in comparison to the other devices. My only concern in this case would be that there is a fair amount of calcium, and we also know that the Accurate is not the valve with the highest radial strength. In fact, it has the lowest radial strength. So there is a risk of PVL in this case, I guess. Although we've seen, and you show the data of scope 1, in which the seal was not yet implemented, but with the Neo 2, the Accurate has a seal which really brought down the PVL up into very low numbers. But I'm curious to see what you will manage to get in this case.
Okay, Dr. Kim, please go ahead. We will watching your implantation, particularly what change in the calcium before and after the accurate nail is a quite interesting point of view. Okay, go ahead.
Yeah, of course, accurate nail expansile force is about 60 or 70% of absolute true, as it is weak. But actual data is very similar or better with accurate. Thus, I think the expansile force is not the only factor to prevent paravalvular leakage. More conformable structure may be lessen the crack around the calcium chunk. The second issue is post-ballooning after deployment of self-expandable valve is a little bit different from the balloon expandable valve because we usually do a post-ballooning with a little bit less than mean diameter. As I think post-ballooning is also performed, but the safety issue of post-ballooning after accurate nail is definitely less than the sapien valve expansion.
In this patient,
Okay, this
the
is,
aortic valve area is 0.9. It's not so tight, and except for the calcium in the extension to from the right coronary concept to the LVOT, the severity of the calcium is not so severe. When we use the accurate nail, is that usually pre-dilation is recommended. Will you do the pre-dilate that one or just the direct?
Pre-ballooning is a prerequisite for accurate nail
Okay.
because of the easiest advance and is easy way to rotate, to adjust commercial alignment is guided by pre-ballooning. Thus, they always recommend pre-ballooning with balloon just 1 millimeter less than medium diameter.
Okay, go ahead.
As we can
Please show
see,
us
we
your
can see the calcium
procedure.
of the right valve that extends toward the LVOT a little bit. Plus, this is a cusp of left view. Once again, we can see the calcium chunk.
Please show us the fluoroscope. Okay.
Plus, okay, then I perform pre-ballooning with 24 millimeter
24.
diameter. Okay, rapid pacing on. Inflate. Inflate. Pace off. 놓고. 오케이. YST 하기. 잠깐만. 플래시 잘 됐네. Balloon, deflate balloon is stopped at the edge of sheath. Okay, I repeat. Okay. 이거 deflate 하면 다 할까? 이거 물 버리고, 물 좀 버리고. The balloon is not good. Which brand? Zimed. Not fully deflated, as it is caught at the edge of sheath. 어떻게 이렇게 불량품? Rotate, retrieve. No.
Dr. Kim, it's Eric. Can I advise you? Push it back again. Don't try to pull it with force, because it is hung on the entrance. So push it back. Right now, just rotate it, and try to rotate it and bring it back again. Push it more front. Go forward first. Forward. Okay.
There it goes. Nope, still won't go.
Okay, if it doesn't work,
Take everything.
inflate 해가지고.
Or you can
if this
gently
doesn't work,
Just
lay
inflate.
try
again
make
and then
make a
deflate.
gentle
Try to
inflation
do a
and
re-wrap again.
deflation again. Okay.
Yeah, I mean, maybe it's winged out. So, yeah, gentle inflation and deflation. If it doesn't come out with that, I would just take everything out and leave the wire and put a new sheath. There it goes. Yep. Okay.
Wire stay. Advance. Advance.
This is a safari wire.
Yes. The sheath is a problem in Boston. It's very weak, easily kinked. Okay, valve. She's okay. I maintained the three-cusp view from the start. Is it three-cusp view?
Dr. Kim, do you always use a semi-compliant balloon? Is that just because of the availability or the size that you picked the ZMAT?
Which one? 6 o'clock?
What do you like to use? I usually use a true balloon for predilatation. Just
Yeah, so do we.
it's been down very quickly, but
Right.
it's more expensive.
전혀 안 하네. 걱정 안 하고. I advance device just one step until the annulus, aortic annulus, and see the position of open cell. OST. Okay, you can see the open cell on the right side. Then I have to turn clockwise a little bit. Can you recognize open cell?
Yes.
Okay. Slowly turn clockwise. And right side open cell disappears a little bit. Then left open cell appear. To overturn. Okay. Cool. Testing. Okay.
Does it matter if it's in contact with the valve when you're turning, or obviously it's in contact, so that doesn't seem to bother it?
Okay, you can see the open cell symmetrically appear on the right and left side. cusp of left view. 뭐하노, 영민이. So where we expected, the open cell appears on the right side, on cusp of left view. Then alignment is well completed. Plus, 자, 빨리 가야지. Problem is usually pressure is lowered during this process. Thus, I have to usually hurry. It's good. Deploy, start. 천천히. Test. Okay.
Now you start the release of the upper crown.
Test.
Okay.
무한히 홍도연 테스트. Deploy. 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 Test. The position is good.
Yes.
You can see the up crown is deployed. Deploy. Then arch is deployed. Deploy. 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 Testing. Deploy. Okay. Then position is good. Save.
So far so good.
자, 시내 한번 해볼게요. 여기서 보여주라니까. 자, 시내. Okay, the marker should be a little bit lower than annulus because this is bigger valve. So I push the system downward. Test. Test. Okay, you can see the sheath is biased into outer curvature of the ascending aorta. Test once again. Okay, I satisfied. So rapid pacing. Test.
And the last
Rapid
movement has to
deployment.
be very quick.
Off. That's finished.
Release
And
of the
retrieval is
last one,
very
you
tricky.
usually do the rapid ventricular pacing, right?
Yeah, nowadays.
Okay.
Because without pacing, the implantation depth is a little bit shallow.
I think it's
And
reasonable.
the strongest force is at the 7 millimeter above the distal edge. So I try to deploy it a little bit deeper. That corresponds really a 7 millimeter depth. Okay. Why stay?
Okay, it's time to preliminary show us the TEE finding in this patient.
Okay. TEE. Dr. 승돌이, 기원.
Preliminary. And please comment.
Wire.
Now I'm showing the
Especially focus in the calcium chunk in the right coronary cusp. The TE finding is very helpful. What happened? What changed in this patient?
내가 할 테니까 너는 이미지만 잘 보여줘.
If it is possible, available, the based on the TE finding, additional balloon is required or not?
Short X view, until now there is a parabolic is not visible, so please search another.
Could you show us the more correct short axis view? You mean the cross section of the valve is not circular, a little bit some elliptical, some eccentric in the short axis view. I know that the paravalvular leakage is not so severe. It's a good sign.
I don't see any PVL. Just saw some central from the wire.
Long axis view is excellent.
오케이, 이거 이제 리무브 합시다. 이거 놔두고. Why stay?
Could you show us the next step? What you did?
이거 잡아주고 네 사로 그냥
김?
아예 사로 주세요.
Did you hear us?
이요.
Hello? Can you hear us, Dr. Kim?
Okay. What did you do?
Their index is about 3.9. A wonderful no regurgitation. Pressure profile. Did you see pressure profile?
여기 왜 안 넣어주세요?
Okay, there is no pressure gradient, and diastolic pressure is narrow, so regurgitation is none. So fluoro.
플로로 띄었습니다.
So as we can see, the first NG after TAVI. 자, 시내 준비. 채웠어. 진규가 어시스트를 잘 안 해봤어요. 뭐.
Did you do the post dilation or not?
No, because there is no regurgitation and no pressure gradient.
Okay.
AR index is wonderful.
Okay.
That's a very, very nice
I
result.
retrieved that
Very good result.
아래로 possible left view. 바텀 좀 맞추고. 바텀 맞아.
So what is important here with this valve is to make the first angio after the implantation with a pigtail in the ventricle. Because the need for rewiring the valve is a little bit tricky here because of destabilization arches. If you get entangled behind the arches, you may dislodge the valve. Okay. That's important with this particular device.
Any tricks if you do have to recross? I mean, just be very careful with your probably not a
just move your AI
Exactly.
back and forth to see that you're in. Because the most dangerous part is that you can go between the arches and the aorta, and then sometimes the balloon will go through. After inflation, it won't go back.
Yeah, okay, that's
And I've seen a case like this, so
Here is another lesson. 내가 고정했는데 또 움직이네. Here is another lesson that this is cusp of left view. I try to line the commissure. The commissure is well aligned with this view. One post on the right side. That is located in commissure between right and left cusp because it is cusp of left view. Left side, two posts are overlapped. That is located in the commissure between right and none or left and none. Thus, this accurate nail is well aligned in regarding to commissure. Thus, in the near future, when we do a coronary access, there's no problem. That is another beauty of accurate nail. No regurgitation. Many people concerned about safety because there's a very big chunk of calcium that extends toward annulus, a little bit to LVOT. But this valve is inherently very soft, conformable. Thus, if we meet ideal oversize index, even though it is weak, but well conformed to the kind of an undulating annulus morphology. Thus, it is superior to Everett Pro, even though it is weaker in terms of paravalvular leakage.
So far, the result is excellent. I'd like to one request for show us the true RAO view. In the RAO view and the AP view is the valve expansion is symmetric, is excellent. In the T finding, the shape of the valve is a little bit eccentric. So please show us the fluoroscopic image in the extreme RAO view or more than about 45. Extreme RAO view.
As you can see, we always perform sweeping fluoroscopic image taking, areocaudal and areocranial.
The range is
Most
not
of
so
patients-
the extreme. It is not fully sufficient to the expansion of the valve. So sometimes in
Such
the
kind of
self-expandable.
rotation angle is enough. There's always annulus is not round, ovoid. Thus, if you see the areocaudal view, it is always diameter is narrower. Areocranial, the widest. Thus, always it is kind of eccentric. Thus, supravalvular design guarantees at above annulus, supraannular valve level, the valve is near to round shape, even though annulus is eccentric. That's another beauty of self-expandable valve.
Supraannular is this the valve? I mean, there isn't that much space. How much above the annulus does it sit?
얼마쯤 될까? 저 밑에 바텀에서부터 그 밸브리프트가 붙어 있는 레벨이. I forgot actual number, but the upper valve leaflet is attached at the center of post. So upper level of valve leaflet is up to the midpoint of post.
Oh, it's very high.
Thus,
Okay, yeah.
thus, if you perform a post ballooning, we always put the balloon upper mark lower than the midpoint of post.
Got it.
Minimize the leaflet damage.
So, Dr. Kim, you are clearly, a fan of this valve and an expert in deploying it. If the size is right, where would you really not use a neo? What type of anatomy or patient would you strongly discourage using a neo?
The most important factor to guarantee the optimal position from the initial deployment process is the presence of calcium chunk. If the calcium chunk is very high, too big, then the upper crown is deployed. We cannot expect the movement of valve leaflet, valve system. Upper crown is deployed, and that force may induce system downward or upward. Such a big calcium is very rare. In this case, we have to concern, but in all other cases, it is not any difficulty, even bicuspid aortic valve.
So you even a heavily calcified bicuspid valve doesn't deter you.
Well, last week we performed bicuspid aortic valve with heavy calcification, but calcium is not wide. Thus, when we deployed the valve, the position was very stable. A perfect result, no regurgitation. Even though there is an eccentric shape at the annulus level, at upper level is round, near to round, no regurgitation.
Dr. Damon, you have experience of the accurate neo. What is your indication to select the accurate neo?
What I think is a important pro of this valve is the lower radial strength, so the low likelihood for pacemakers. I think is a good argument. You have somebody with a pre-existing bundle branch block or AV block, then those patients may benefit from an accurate. And otherwise, I think it's I agree with Dr. Kim. It's a very universally applicable system. So yeah,
So a worthy competitor.
Yeah, I agree that actually neo has a phase feature, minus table. In some kind, it is very similar to Sapien. For example, it is very narrow. Risk of AV block is like Sapien, and coronary accessibility is like Sapien. But other virtue, safety, hair, and coronary obstruction is like Evolut. Thrombosis like Evolut, orifice area like Evolut. Thus, in some aspect, actually neo has good things both from Sapien and Evolut. Thus, I believe actually maybe the working horse TAVI valve. And if it's impossible to accurately deploy, then we consider Sapien or Evolut.
Okay, Dr. Kim is the excellent result. Would you summarize your cases and then we will move to Samsung Medical Center?
Okay, this patient has just a big body size, a little bit obese, 81 years old. It's very healthy. Thus, I consider the longevity of valve. That is determined by orifice area. The less prone is to thrombosis and future coronary accessibility. Of course, his membranous septum length is not enough, but I believe pacemaker rate is lowest with accurate neo because it is soft, even low, than Sapien. That's the reason why I chose accurate neo.
Okay,
Thank you very much for your
congratulations.
attention.
It's an excellent result. Okay, congratulations.